32 साल। और ये गांठ आपको कब से लग रही है, उसको हटा दो वहां से। 32 साल। और ये गांठ कब से हो रही है? 2 साल। तो इसमें कोई दर्द वगैरह तो नहीं होता? और अभी कुछ आपको लग रहा है कि तेजी से बढ़ रहा है या हल्के हल्के बढ़ रहा है? बढ़ रहा है। इसके अलावा कोई और आपको कोई परेशानी होती है गांठ के अलावा गले में? You started? No.
Yes, sir.
अच्छा। So we have a young patient, 32 years of age, with complaints of swelling in the neck for last 1 year. This patient does not have any other complaints except the swelling in the neck, and this swelling is gradually increasing in size. She has no difficulty in swallowing, she has no respiratory difficulty, and she does not complain of any other swelling in any other part of the body. She noticed this accidentally about 6 to 8 months before, and after that she has been observing this for last 1 year off and on, but now she says that the swelling has become bigger than the initial swelling, and hence she consulted the medical profession. So आपने किसको दिखाया यहाँ पे पहले? इस गांठ के लिए कहाँ किसके पास गई थी आप? 2 नंबर वार्ड में। इससे पहले किसी और डॉक्टर को दिखाया था? कहाँ? 2 साल पहले भी दिखाया था? उस वक्त भी ये गांठ थी? अच्छा। She says that about 2 years back also she had visited the hospital and there was a small swelling in the neck, and she had consulted some consultant who advised her to undergo surgery, but she did not undergo a surgery. Now whenever you have a patient with a thyroid swelling, 2 or 3 things are very important in the history. One is the residence, because it is most of the time it's an endemic disease, and if she is coming from an endemic area where the iodine deficiency is there, then in those cases it is more common in the family and in that locality. आप रहने वाली कहाँ की हैं? ये डिस्ट्रिक्ट कौन सा आता है? बुलंदशहर. So is it endemic area? No. Generally it is endemic in those areas, in hilly areas, and where the iodine deficiency is very common, and also those patients who take salt which is not iodized. So that history is not there in this patient. She is coming from an area where the patient is taking a normal iron and this iodine salted, plus she is not from an endemic zone. Then the other thing which you have to find is whether this swelling is associated with symptoms such as tachycardia, tremors or proptosis. तो आपके हाथ पैर तो नहीं कांपते काम करने में? नहीं. अच्छा. और देखने में आंखों में कोई परेशानी होती है या आंख आपको लग रहा है कि बड़ी हो गई है? कभी तेजी से आपका दिल धड़कता है? ऐसा कभी महसूस हुआ कि लग रहा है तेजी से हार्ट बीट कर रहा है? नहीं. So from the history it doesn't appear that this patient had any history of tremors, or she had tachycardia, or she had proptosis of the eyes, or blurring of vision. So nothing of that sort. Plus there is always a history of pretibial myxedema and pedal edema. पैरों में सूजन तो नहीं आई कभी. So there is nothing like that. So the history doesn't appear to be because of having involvement of the toxic symptoms. So these toxic symptoms, major toxic symptoms include tachycardia, proptosis, and tremors. So none of them are present in this patient. So now with this background that this patient is coming from a non-endemic zone with a swelling which is there for last 2 years, and it is gradually progressing in nature, and she does not have any toxic symptoms. So now then you have to think of some other benign lesion, or there is gradual transition to malignancy. So now we have to examine the patient to first see two things. First, what is the size, shape and the type of the lesion in the neck, and whether patient is having any of the toxic symptoms which we have discussed. So there are various methods. Of course, before we go to the systemic examination or the thyroid examination, we must have the vital signs. So you have to see for pulse, you have to see for temperature, you have to see for respiratory rate, and any difficulty in breathing. Nothing of that is present, but we just like to have, of course, there is some sweating of the hands, which is because of anxiety rather than the disease. And what was the pulse rate in the ward? So when she was examined in the ward, her pulse was 78, which is normal. So there is no tachycardia, and apparently there is no proptosis. दोनों हाथ आगे करिए, ऐसे खोलिए, उंगलियां खोलिए, हाँ, फिंगर अलग अलग करिए. Apparently there are no tremors. So fingers, मुंह खोलिए, जुबान बाहर निकालिए, आगे जीभ बाहर निकालिए, मुंह खोल के बड़ा पहले मुंह खोलिए, जीभ बाहर निकालिए. Also there are no specific tremors of the oral cavity, and of course as you can see that there is no proptosis, and she is having normal eyes, so there are no eye signs also. So as far as general examination of the patient is concerned, she is not having any tachycardia, she is not having any tremors, and she is not having any eye signs. So apart from that, you will go for general examinations such as icterus, pallor, lymphadenopathy, axillary, neck and pedal edema. Pedal edema we like to see. For pedal edema, पैर दिखाइए. In thyrotoxicosis, there is pretibial myxedema. That is there is no pretibial myxedema and there is no pitting edema. It's all normal. Now coming to the thyroid examination, you have to first decide what is the type of thyroid in this. A large thyroid requires a different examination, and a small thyroid requires a different examination. So there are various methods of examination of the thyroid gland. One is the classical method, second is the Lahey's method, third is Kreis Junior method, and fourth is the Pizzolo's method. So all these four methods are not employed in every patient. It will depend upon what type of the neck the patient has and what is the type of the thyroid gland. So the most common examination is the classical method, which we will demonstrate in this patient, and the second commonest is the Lahey's method. So both of these examinations are done for an average size thyroid gland. Pizzolo's method is done in a patient who is obese and who has got a thick neck and a very small thyroid gland. And Kreis Junior method is done for a very small thyroid and where the second lobe is not seen or not palpable. So now in this patient, she is neither obese, neither she has a thick neck. So this Pizzolo's method is not indicated in this patient. Kreis Junior again, it's very small neck thyroid swelling. It appears to be a significant size thyroid swelling. So again, Kreis Junior method would not be employed in this case. So what is employed, will be employed in this case is basically classical method and the Lahey's method. So in classical method, you have to examine the patient both from the front and from the back. So in this patient, since I'm sitting in front of the patient, and we'll expose the neck and ask her to look, flex the neck, गर्दन थोड़ा झुका दीजिए, and we will give her a water to drink so that we can see the movement of the thyroid gland. इसको पानी पीजिए, घुट आधा थोड़ा एक घूंट लीजिए, एक घूंट लीजिए, नहीं मुंह में पकड़ ग्लास मुंह में लगा लीजिए, मुंह में पानी डालिए, हाँ अब हटाइए, अब सटकिए उसको, एक बार फिर से करिए, हाँ निकटिए, हाँ. So on inspection we can see, of course all 4 steps have to be followed: inspection, palpation, percussion, yes or no, but auscultation is important. So in this case we will do inspection, and then we will do palpation, and then we will do auscultation. So inspection, we have seen when she is drinking water, what is happening is we see that the swelling is moving up on deglutition, mainly on the right side. Right half the swelling is more prominent than the left half, and it is moving with deglutition. The swelling is mainly, as you know, the thyroid is butterfly shaped. So it has 2 lobes and it is joined by the isthmus. The isthmus generally lies over the trachea, and the 2 lobes are on the either side. So now in this case, if you see very carefully, there is more bulging on the right side and the left side appears to be very small or normal. So on inspection, it is appearing that the swelling is mainly confined to the right lobe and the isthmus, whereas on inspection the left lobe is not visible clearly. So now again you will ask her to deglutate again and see whether it is going behind the sternal notch on deglutation. पानी देना, पानी पीजिए, एक घूंट लीजिए मुंह में, बस अब सटकिए, पानी सटक जाइए. When she is drinking, what is happening is the swelling is going up and there is a definite space which shows that the swelling is not going into the suprasternal notch. So it is above the suprasternal notch even on inspection. Of course, we will confirm it by palpation. Now then what we have to do is, you have to see for any pulsations, any engorged veins and any other swelling other than the thyroid swelling. There is no engorged veins, there is no pulsation, and there is no special changes in the skin also. The other thing is, we have to confirm whether we are dealing with a thyroglossal cyst, because all swellings which move, there are 4 types of swellings which move on deglutation. The first swelling is the thyroid gland, the second is the thyroglossal cyst, and third one is pretracheal and prelaryngeal lymph nodes. And also sometimes there is some other lesion in the neck. So first, the most important thing which we have to differentiate is whether we are dealing with a thyroid swelling or a thyroglossal cyst. So for that, we will ask the patient to open the mouth and deglutate. तो मुंह खोलिएगा बड़ा सा. Now before we do anything, we have to see the tongue is inside, and since the thyroglossal duct is attached to the tongue, so when the patient protrudes out the tongue, the swelling should move if it is a thyroglossal cyst. So that has to be verified on examination. अब मुंह खोल लीजिए एक बार, अब जीभ बाहर निकालिए, come closer. You see, जुबान अंदर कर लीजिए, फिर मुंह खोलिए. This is a very important step. First you have to ask the patient to open the mouth, not to protrude the tongue. Once the mouth is open, then you ask for protrusion of the tongue. जुबान बाहर निकालिए. There is no movement over the thyroid swelling. So that means it is not attached to the tongue, under Kaliji. So it is not a thyroglossal cyst, and because on protrusion of the tongue, the swelling is not moving up. If it is a thyroglossal cyst, then since it is attached to the tongue base, wherever the patient protrudes out the tongue, the swelling will go up. So in this case, we are sure that it is not a thyroglossal cyst or thyroglossal lesion. Now, then we see the thyroid by doing the classical method. We stand behind the patient and we ask the gardan jhakaiye thodi si. Now, what we are going to do is we reach the upper part of the swelling over the trachea. So my finger is over the trachea, gardan jhuka lijiye thoda sa, and it is tracing the thyroid gland to the lateral side, and it is going behind the thyroid lower end and coming to reach the area where the thyroid is ending. So on this side there is hardly any swelling. So left side there is no lesion. On the right side, my finger is palpating the gland all around, and it's going behind and then coming again forward to reach below the thyroid gland. So we are encircling the gland on this side completely, and now we assess the size. So the size around appears to be 5 centimeters approximately. We will take a scale when we are standing in front, and the upper limit is here and the lower limit is above the clavicle. It's not reaching the suprasternal notch. So only right half of the gland appears to be enlarged with some part of the isthmus inward. Now then you will also see the consistency. The consistency is firm, and I can feel one nodule also in this gland. So there is a nodule which is about 1.5 to 2 centimeter, which is firm to hard in consistency. So this is the nodule which is there, and you can see on the photograph also on examination. And posterior part of the gland is firm, whereas the anterior part of the gland appears to be firm to hard, and it is nodular, and it is non-tender. Now, so on palpation we have found that the gland is only on the right side. It is occupying the right lobe and part of the isthmus, and it is a nodular gland. It is non-tender. And now we come to the front, and then again we confirm the findings. Again, when you see that my finger is over the isthmus, and now this is the lower limit of the swelling and this is the upper limit of the swelling. Now give me the scale. So this is the posterior limit and this is the anterior limit. So this is around 8 centimeters, and vertically this is the upper limit and this is the lower limit, around 4 centimeters. So it is 8 into 4 centimeters. The skin is free, not fixed to the gland, and on deglutition vertically and is moving, and this part of the swelling is having a nodule which is rounded in shape, and it appears to be around 2.5 into 2.5 centimeters. So there is a separate nodule in the anterior part of the gland, and the posterior part is not having any nodule. Left lobe, or that is the left lobe, is absent, and it is not palpable, and it is up to the middle of the isthmus on the right side. So now this examination is known as the Leahy's method. In the classical method, in which you have gone through the gland upper limit, then you have gone to the lower limit, and you have gone to the extreme. So this we have traced the gland, and at the same time we have felt the consistency, tenderness, fixity, which is not there. So that is about the classical method. Now we will do the Leahy's method. So in Leahy's method, what we do is we shift the gland to the lateral side by pressing from one side. So now this is the area, left side we have already said there is hardly any lymph enlargement of the gland. So from the left side we are pressing so that this gland now becomes prominent. Now when it becomes prominent, then we do the whole examination. That is the upper limit, then the posterior part, then the lower limit, and again, what is the advantage of the Leahy's method is that this finger goes behind the gland. So you can feel the behind posterior part of the posterior part of the gland also. So this is the Leahy's method, but in this case it cannot be done on the other side as there is no gland available on the not enlarged gland. So what these two examinations have confirmed those findings which we have saw earlier. That means it is moving with deglutition, it is not going behind the sternal notch, it is confined to the supraclavicular area, and it is the size which we have already said is confirmed. So no other finding is there except what we have already said. So we have completed the inspection, we have completed the palpation, and now we do the auscultation. If there is a stethoscope, no. The part auscultation is part, again, since it is not a very vascular swelling, we will say that it is non-vascular and there is no bruit, but that is generally seen in primary thyrotoxicosis, where there is a uniform enlargement of the gland and both the lobes are enlarged, and it is a de novo enlargement of the gland with signs and symptoms of thyrotoxicosis. In this particular case, now we can conclude, and then the next thing is to see for lymph nodes, because this is only the enlargement of the gland. So now this enlargement is localized and it has a nodule. So now once there is a nodule, there is a suspicion of either it is a benign nodule or a malignant nodule. So to confirm or to find out any other finding related to a malignant nodule, the first important thing is the presence or absence of lymphadenopathy. So for that we will do this classical lymphadenopathy. Gardan chukaiye, submental, submandibular, preauricular, postauricular and occipital on that side. Submental, submandibular, preauricular, postauricular, occipital. They are not. Then jugulodigastric, jugulo-omohyoid and supraclavicular. Similarly on this side, jugulodigastric, jugulo-omohyoid and supraclavicular. So on examination, no lymph nodes are palpable in the vertical chain or in the transverse chain. So now the examination is complete. As local examination is concerned, if you have a suspicion of distant metastasis, then more examination is required of other systems, especially the bones and the lungs and the liver. So that appears to be not present, so that can be investigated also. So now coming back to the patient's summary, this lady has a swelling in the neck for last 1 year, but she says it was also seen earlier 2 years back, and this has been a gradually progressive swelling. It is painless, not on examination. There are no signs of toxicity. However, there is a swelling which is moving on deglutition, and it is confined to the right lobe and some part of the isthmus. On local examination of that particular part, it is around 8 centimeters into 6 centimeters, and it is firm to hard in consistency. Posterior part of the gland is firm, whereas the anterior part has a nodule which is firm to hard in consistency. So now, and there are no added lymphadenopathy or there are no lesions suggesting a distant metastasis. So now once we have this finding, we will say that this is a case of nodular goiter confined to one lobe, mainly the right lobe. So nodular goiter can be of two types. It can be solitary thyroid nodule, or it can be a toxic nodule, or it can be a non-toxic nodule. Since she does not have any features of toxicity, So toxic nodule is ruled out. So now remains there is a goiter which has a large nodule in the right lobe. Left lobe is insignificant on clinical examination. So what is this nodule and what is the disease? So the important thing in this case is the nodule. So this nodule can be a benign nodule or it can be a malignant nodule. So that requires assessment by various investigations, but clinically it appears to be a malignant nodule. Why? The consistency in this case is hard, and although it is a duration is a very long duration, generally thyroid malignancies are slow growing. So this could be one of those presentations in which the patient has a swelling for a long period, but now since the patient has a hard swelling, this has to be investigated by different methods. We have to have an ultrasonography, we have to have a FNAC, and depending upon, of course, thyroid profile is the first thing which has to be done to confirm whether it's a toxic or non-toxic. Of course, clinically it is a non-toxic nodule. So that investigation will confirm Bethesda staging, and of course the results of the fine needle aspiration cytology will tell us whether it is a neoplastic lesion or what type of pathology is this. So with the clinical examination, we have come to this conclusion that this is a thyroid swelling involving the right lobe having a nodule. So it's a nodular goiter, most likely malignant. Thank you.